if one of you can just answer for the group. I mean, are you guys all sophomores, juniors? Are you guys seniors applying right or in the middle of the application process and waiting for acceptances? Like where are you guys in the process? And also, I guess if you can tell me a little bit about your organization and what you guys are trying to do with your meetings.
Thank you so much for asking. So yeah, we're Caduceus, and we're a small pre-med org that's trying to provide a community for uh, other pre-meds, and more of a social org where we give them volunteering events, philanthropy, and opportunities to meet doctors like yourself. And we are a mix of sophomores, juniors, seniors, freshmen, like the whole lot. Everyone is equal distribution. Everyone's at different points in their journey.
Wonderful, wonderful. So, I am quite open to discussing whatever you guys think would be useful. I thought I would start by just giving you a little bit of a kind of explanation and history of my own path in medicine and how I ended up in the specialty that I'm in, and I'll explain my specialty a little bit. And then I have I'm on the Dell Med faculty and I lecture around quite a bit. So I have some PowerPoints that I can kind of pull up and just give you guys a little sense of our specialty of oculoplastic surgery. Would that be useful? Does that kind of sound like a good kind of framework? And, also knowing that it's Super Bowl Sunday, I won't go on and on and on. We'll probably try to wrap up in I'll probably try to limit my comments to about 20 minutes. And then I'm open to helping to, take any questions, answer any questions that you guys might have. Cool. Okay. So my name is Tanju Nakra. I'm an oculofacial plastic surgeon that I'm on combined positions with full-time faculty at Del Med. And I'm also work in a private practice in Austin called TOC Eye and Face. Um, I'm an oculofacial plastic surgeon. And what does that mean? Well, I'm a reconstructive and cosmetic surgeon of the eye and face region. And my original training background was in ophthalmology, and then I did fellowship training afterwards. So after college, I went to medical school for 4 years, and then I did a transitional internship, and then I did a 3-year residency in ophthalmology at UCLA, and then after that, I did a 2-year fellowship in oculofacial plastic surgery, also at UCLA. And then I did an additional 1-year fellowship in kind of general cosmetic plastic surgery to just add to my skill set further. And after that is when I moved to Austin about 16 years ago to join the TOCI and face practice here. And I'm thrilled that the medical school has come onto the scene. I'm a pretty academic surgeon. So even though I was historically in a private practice, I have been involved with research projects and teaching throughout my entire career. Publishing is a big part of what I like to do, and teaching. So we have Del Med ophthalmology residents that rotate with us continuously in our practice, and we also have fellowships. I'm a fellowship director in oculoplastic surgery, meaning that people who have gone through an ophthalmology residency program who choose to do additional fellowship training in oculofacial plastics can come and spend 2 years with me and my partners to become an oculoplastic surgeon. And so my background is in ophthalmic surgery, which is a very microsurgical subspecialty. But my fellowship training expands outside of the eye and the orbit to include eyelids and facial structures. And so, on a weekly basis, I probably am in the operating room for 3 days, and then I'm probably in clinic for 2 days. I see children, I see adults, I see elderly people. We take call at Del Seton. Just today, we actually repaired an eyelid laceration of a UT undergrad who somehow split his eyelid open during a sporting event earlier today. So we take call and manage things like that. We also manage fractures around the face and the eye area. And when there's cancer that comes up on the skin of the eyelids in the face, we're oftentimes called to help do reconstructive surgery for those kinds of patients. Um, and so what do I like about my specialty? Well, one thing that I don't know if you guys realize, but I'm sure you're all very focused on getting into medical school, and maybe you have some preliminary concepts of what kind of specialty you might be interested based on, whatever limited exposure you might have to specialties. And I was in the same boat. And so I went to medical school starting in 2001. And one of the things that I guess really shocked me upon arriving at medical school is that I've been working so long to get there. I didn't realize how much of a Pandora's box it was to try and identify a specialty. And it felt like a huge, huge decision because whatever you choose, you're going to be doing that for the rest of your life. And so, choosing your specialty wisely is very important. There are lots of examples of physicians who, in retrospect, wish they'd gone a different path. And it's something that if you don't enjoy what you're doing every day, then it can really be a frustrating experience. I personally feel incredibly fortunate to have found this little tiny corner in medicine that I didn't even know existed until I was a third or fourth year medical student because it's such a specialized area. And I was just lucky enough to have um, an excellent occulofacial plastic surgeon at my medical school that I ran into late in my process. I was actually not entering medical school thinking about surgery, just because of some of the stereotypes that exist about surgery wasn't something that I thought was what I was looking for. In fact, my parents are both psychiatrists, so I actually founded the psychiatry club at my medical school. But when I did my clinical rotations, I realized that, I actually have a background in fine arts. I did a fine arts minor and I play musical instruments. And so it became pretty obvious to me that working with my hands, doing meticulous work was going to be something that I would really enjoy. And so then I started looking at surgical specialties and I was considering ENT. Because of the, I think, fascinating anatomy of the face. I was considering ophthalmology because the microsurgical detail that ophthalmologists perform is fascinating, and um, the toys that ophthalmologists get to play with in terms of the lasers and the rapidly evolving tech interface that ophthalmologists use, I thought was also fascinating. But then I was drawn to the artistic sides of plastic surgery. And I also was interested in neurosurgery. So those are my interests. And then it turns out that oculoplastics really, I think, covers all of those areas in many ways. We do skull-based surgery in conjunction with neurosurgeons. We do intricate surgery that require loops and microscopes to work on the eye region sometimes. And then, we're doing creative things like reconstructing faces from trauma and cancer, and then also cosmetic surgery. So that's, I think, an overview of oculoplastics and how I ended up choosing my specialty. Um, Let me spend a few minutes just kind of sharing some PowerPoints here, just to kind of give you a little taste of some of what we work with routinely in our specialty. Can you guys see this right here? This is it says AAO Basic and Clinical Science course. Is that right? Can you see that?
Yes.
Okay, great. This is actually a lecture I gave the Delamed residents last year, and it's just sort of like, I would say, a taste of some of the intellectual information that comes into the world of ophthalmology and oculoplastics. So the American Academy of Ophthalmology actually has a basic and clinical science series where there's, I think, 12 books that all the residents have to master and get tested on during their residency. So this is just one of the chapters in the oculoplastics book, but it's the anatomy chapter, and we talk about and teach the residents orbital anatomy, relating to how the eyes and the eye structures fit into the face and the relationships with the sinuses. We have our residents memorize and learn a lot of orbital anatomy, which includes the bone structures around the eyes and the eye socket. So the orbit is the eye socket, basically. And within the orbit sit all of the structures of the eye, the eye muscles, the fat that surrounds the eye structures. And here's an example of a kid with an infection called orbital cellulitis. And on this CT scan, you can see this is the normal eye over here. And on this side, there's this round mass extending from the sinuses that are opacified. So this is a sinus infection that's spread into the orbit and is now pushing on the eye and threatening vision loss. And so this is the kind of case that we would do an urgent surgery and come and drain this abscess in the orbit, and sometimes in conjunction with an ENT surgeon that's also draining the sinuses to kind of take care of this particular type of infection. I think other interesting things that we study in our specialty is, I was mentioning earlier my interest in neurosurgery. So a lot of the deep orbital structures really interface with the neuroanatomy of the skull base. And these are all regions that we operate on for tumors that might exist within the eye structure, within the orbit, and trauma that might occur in the region. So this is all anatomy that we're continuously fascinated with and interface with on a routine basis when performing procedures in this area. And we also work with the sinuses around the eye structure. And so these are all areas that our residents are also exposed to and learning during their education. So that's just one, I think, taste of the anatomy that we see on a routine basis. Let me also share a couple of other PowerPoints here. Okay, so let's take a look at. Sorry, I'm not going to share. I'm going to change what I'm sharing here to a more practical exploration of some of that orbital anatomy that I showed you there briefly. There it is. Okay, so you should be seeing something that says balanced orbital decompression. Can you guys see that?
Yes.
Great, thank you. Okay, so one of the conditions that we see in our specialty is thyroid eye disease or Graves' disease. This is a condition that is an autoimmune inflammatory condition that results in bulging or proptosis of people who have this condition. It can create a lot of swelling. It can lead to exposure of the eyelids, disfigurement, and it can even cause double vision where the muscles that surround the eye, there's 6 muscles around each eye. It's actually quite fascinating how complicated the neurology is of how the brain connects to the eye and the 2 eyes and how the eyes function for us to be able to see every day. And so thyroid eye disease is one of those conditions that can actually affect that function. The orbit's a pretty rigid compartment, and swelling in the region is not tolerated very well. Here you can see a CT scan showing on the right side, we're looking at a healthy orbit, but on the left side, you can see these big, fat kind of masses that are adjacent to, this is the eyeball and the optic nerve coming out behind it, but those swollen masses adjacent to it are the muscles around the eye called the extraocular muscles that are very swollen in thyroid eye disease. Here's another CT scan, again, showing the normal side on the right. And you can see these thickened areas that are basically strangulating the optic nerve here. So these are situations where we have to intervene and perform what's called an orbital decompression surgery. And this is a surgery where we actually make an incision on the inside corner of the eye. This is called the caruncle, which is a little fleshy mound on the inside corner of the eye. So we make an incision through the caruncle and cut into the conjunctiva and expose our plane, which is basically designed to split the space between the ethmoid sinus and the orbit so we can get into this cavity. And once we can get into this cavity, again, utilizing some of the anatomy that we were showing in the previous presentation, once we get into this space in between the orbit and the sinus, we can actually see the ethmoid bone in surgery. Just, here's a surgical view of that. And the goal is to actually break into the ethmoid sinus and break into the maxillary sinus and create space so that the muscles that are engorged and enlarged can move into the sinuses partially and take the pressure off the optic nerve and thereby, save the person's vision. And so, we're trying to create space by pushing into these ethmoid and sinus spaces so that, again, there's room for the orbit to expand into. And there's various ways to perform orbital decompressions, but here is an example. The top image is before surgery, and you can see the eye sockets, the orbits on each side. There's expanded and swollen muscles, and then in between, you see the black space is basically the air inside the ethmoid cavity, the ethmoid sinuses. And you can see in the lower image that the ethmoid sinus has been disrupted by surgery, and now this muscle that was pushing firmly on the optic nerve has now fallen into the ethmoid sinus, taking pressure off the optic nerve. And there's other ways to do decompressions. We also go into the outer space out on the outside wall of the orbit and create space by drilling into a thick bone that exists in the outer wall. So the outer wall has these thick bones. This red bone is called the sphenoid bone. And on the other side of the sphenoid bone is the cranial fossa, or where the brain sits. And so this is where we go when we're trying to perform a more substantial orbital decompression. So here's someone who has very swollen eyes, and here is the patient after performing a big decompression. So you can see in this image, you see all the white bone on the outside of the orbit. And here, the bone has been drilled down and almost fully removed to allow the muscles to shrink into these spaces. And again, here's another image with a CT scan showing the pre-op space, and then here after surgery, how much space we've created. And so again, here's just some examples of patients who've had orbital decompressions to make their eyes look more normal. So that's just one little taste of what we do when it comes to some of the functional surgeries. And then let me give you just a little taste of some of the eyelid surgeries that we do. Can you guys see this presentation? It's called Surgical Management of Periorbital Aging.
Yes.
Okay. So the other end of the spectrum of what we do is we have lots of patients coming in who, have aging changes of their eye and their face, and they want us to do something about it. And sometimes when the drooping of their eyelids is very severe, as in this patient here, this actually cuts off their visual field and affects their ability to see. So insurance companies actually cover these kinds of upper eyelid surgeries to be able to allow patients to see better. This patient also had cosmetic surgery on her under eyes and on her forehead to kind of smooth out her eyes. And so a lot of times we're doing combined procedures like this, where we're doing some functional surgery for vision purposes, but then a patient also is interested in trying to make their upper face look more youthful. And so we'll combine these procedures together. And in these cases, we're oftentimes working with a lot of the anatomy around the eyes and in the face. So here are some of the muscles and the structures that we are interfacing with surgically when we're doing eyelid and facial surgeries. We're oftentimes thinking about where the location of the nerves are to avoid nerve injury. Not just, as you may know, there's two basic types of nerves in the body. There's motor nerves that supply muscles to allow us to move. And then there's there's sensory nerves that allow us to feel our face and feel our scalp. And so here's an image showing the supraorbital and supratrochlear nerve, which we interface with frequently when doing eyelid and facial surgery. And this allows us to feel our forehead and our face. I don't know if you've ever noticed that sometimes when you have a headache, people oftentimes find that they can relieve their headache a little bit by pushing that little notch right above your eye. If you put your finger right above the inside corner of your eyebrow bone, you'll feel a little hole in the bone with a couple of structures coming through it. That's your supraorbital and supratrochlear nerve. And if you push on it really hard, they're a little tender because those are sensory nerves. Now, sensory nerves generally don't have any motor capacity, so injuring these nerves doesn't cause any paralysis. But on the other hand, here's an example of a facial nerve branch, or a motor nerve. The facial nerve comes from behind your ear through your parotid gland and has branches: the frontal branch, the zygomatic branch, the buccal branch, the marginal mandibular branch, and the cervical branch. And there's mnemonics that you learn in medical school to memorize, hundreds and hundreds of medical facts. One of the ones that I remember from medical school that I still think about sometimes is two zebras bit my cheek, is the temporal, zygomatic, buccal, marginal mandibular, and cervical branches. And so there's all sorts of cute mnemonics that you'll learn. Some of them are rated G, some are PG, and some are rated R. Usually those are more memorable. I won't repeat any of those here for you guys. But anyway, going back to some of the anatomy here, in surgery, we will make incisions to perform various different maneuvers. Here you can see a patient who had an upper eyelid surgery to take off some of the extra skin and to tighten the muscle so she can see better. And then this is a little image of, and a little video of the kind of exposure we achieve in surgery when we're trying to perform brow lifting. So we're releasing the forehead off the bone, and this allows us to then elevate the forehead and the cheek for cosmetic purposes. And to fixate the forehead into this new location, we'll oftentimes use a drill to give us access to placing a suture. So using a drill to the outer table of the bone here, and turn the volume down here just a little bit. So the skull bone is 1 centimeter thick, and we're actually creating a drill hole in the outer table of the frontal bone. And the whole purpose of doing this is so that we can actually pass a suture through this space. You can see that we're passing the needle through that hole we just created. And because this bone hole is in the outer part of the bone, it actually has no interface on the internal aspects of the skull or the brain, because they're just working on the outer space. And here's just an endoscopic view of the same thing, where we are using a drill. And the precision of this angle obviously is important to be able to ensure that we're not going all the way through the bone. And then, once we have passed that suture, then we can use that to fixate the brow up into a higher location. Sometimes we use devices that are manufactured to help us with elevations. Here's an endotine ribbon device that we're using to elevate and fixate the cheek up into a higher position. So here's the endotine device going into the face here. And once we place this device, sorry, this video is not that obvious, but anyhow, this is an example of a patient who has a paralyzed right face from a Bell's palsy. So there's all sorts of reasons why people might have a paralyzed face. You can see her left side looks pretty normal. The right side's all droopy. And in fact, when she tries to move the right side of her face, she can't, because her motor nerves are injured from a condition called Bell's palsy that's irreversible in her case. And so because of the drooping, her lower eyelid was hanging down, and every time she blinked, the eye wouldn't close all the way. So we lifted the right side of we lifted the right side of her face and tightened her eyelid to be able to bring this entire facial continuum up to support the eye. And we did this with this endotyne ribbon. And now she can close better, her eye functions better. This is partially covered by insurance, and obviously it looks a lot better too. We also get to do fun things with lasers in oculoplastic surgery. This is a patient who had a CO2 fractionated laser to be able to get smoothing of the skin around her eyes. And this is just a kind of a quick example of using laser technology in our specialty to be able to actually resurface the superficial layer of the skin. And these are techniques that we publish on routinely. This can achieve a very nice outcome for patients for smoothing the eye area. So there's a lot more I could cover, but I'll just kind of stop right there for now, pause for questions and happy to discuss anything, whether it's something you just saw on the presentations that I shared briefly, whether it's something about a career in oculoplastics or ophthalmology, or really anything in medicine in general. I'm happy to help you guys down in your pathways.
I have a question.
Yeah.
So how do you balance your personal life with a career in medicine?
A great question. I think that you have to you have to play a long-term game with that very important question that you asked. So currently in my life, I work about 4 to 4.5 days a week. I try to take Fridays off. My son is actually at a school that's right on the edge of your campus where it's Monday to Thursday. It's called Longview. It's a little micro school there. And so I try to spend Fridays with my children. I have started to take less call as I've kind of gone further into my career, so it disrupts my weekend life a little less. Anytime my wife tells me we should take vacation time, I take vacation time and go travel with them and go make memories with my family. But on the other hand, when I am working hard. I enjoy working hard. I have a very busy clinical practice. I am constantly working on research ideas and publishing and traveling to meetings. And you just have to develop your efficiency skills so that as you have moments either during the workday or my son goes and he's on the Longhorn Aquatics water polo team that includes high schoolers. And so he's got practice on Tuesdays and Thursdays from 7:30 to 9. So I sit there in my car at the edge of your campus and I open up my laptop and I get to work. Sometimes I will wake up before the rest of the family does, and I'll work from 6 a.m. to 8 a.m. on Saturdays just to get stuff done. So these are efficiency tactics that I'm sure you guys are all starting to develop even right now in college, and continue to develop those efficiency tactics so that they will serve you in medical school and residency and beyond. Having said that, if you're signing up for a career in medicine, I'm sure you realize that you have to be prepared to devote your entire focus of your life, basically from now through residency, to medicine. And you're just going to have to accept the fact that there'll be times when your friends are going out on a Thursday night and you're not going to go with them, or your family is making a trip but you've got exams coming up and you're just not going to be able to do that, or it's summertime and rather than traveling you're working in a lab. I look back at it all and I worked really, really hard all the way through undergrad, medical school, residency. I made massive sacrifices, but I feel it is worth it. The end justifies the means. You have to just be ready to sign up for it and, put your nose to the grind. And I feel that sometimes a medical career can be daunting. I'm sure you've got friends who are not pre-med who are wondering why you're getting yourself into something that's going to be this intense and take this much out of you. But the reality is that it doesn't go on forever. It's a limited time for you to go through medical school and residency. And then the secret that no one really tells you is that after residency, you get to decide how you spend your time. And there are people who have very relaxed schedules or make very balanced decisions with their lives after residency. And it's not just about choosing a career like dermatology, versus neurosurgery. You can be an extremely hardworking dermatologist with very little time. You can also be a more relaxed neurosurgeon. I mean, every specialty you can dial it up and dial it down. So don't be intimidated. The ends justifies the entire process. And I'm here to tell you, a career in medicine is worth it. Professionally, I feel I have to pinch myself. I go to work every day and it's fun. I enjoy what I do. I love talking to my patients and seeing them in the clinic. I love going to the operating room and working with my hands and doing very complex but challenging but rewarding and fun things in the operating room. I love teaching the residents and fellows, and everything about it is enjoyable. So I know that's kind of a lengthy answer to your question, but in short, work hard now, and you'll be able to decide how to spend your time later, and you will have flexibility.
Thank you.
I have a question as well.
Sure.
When it came to finding such a niche specialty, would you say that your medical school did a good job of introducing you to those kind of things, or did you do a lot of personal research to find your thing?
That's a great question. Yes, my medical school did. So I went to Washington University undergrad. I went to Rush Medical School in Chicago. I did my internship at Northwestern, and then, as I mentioned earlier, my residency and fellowship was at UCLA. My medical school years was in 1997 to 2001. I know you guys were all very young at that time. Back then, most medical schools worked on a traditional curriculum where you had 2 years of preclinical and then 2 years of clinical. And we rotated on all the specialties. I know Del Med and a lot of medical schools now have a very different process. And I think that the modern medical school approach of letting people have a shortened course through preclinical, and then getting into clinical rotations a little more quickly, I think is really wonderful. But I also know that there's a little less, you kind of have to know a little bit more getting into medical school, what kind of specialty you think you might be interested in, because the competitive specialties, you're going to have to start gearing up and building your experience and research pretty early on to be able to be competitive. And so I think that you have to start to expose yourself to different specialties even now, in undergrad, so that you have a sense of where you're headed. And sometimes serendipity allows one to get into a niche specialty like I did. I think if I were at a different medical school, I just happened to have an oculoplastic surgeon at Rush who ended up being one of the presidents of our society and was an iconic, leader in our specialty. And I thank her so much for, taking me under her wings, because I went to my residency program already knowing that I was interested in oculoplastic surgery, so that I was able to choose a residency program that was competitive in oculoplastics, because oculoplastics is a very competitive fellowship to get into. And so I was kind of lucky in that way. So I guess my advice would be, start thinking now. Start exposing yourself and trying on the concept of, okay, do I see myself as a procedural oriented physician, or am I not procedurally oriented? If I'm not procedurally oriented, do I like the big picture or do I like little details and niche specialties? If I am surgically or procedurally oriented, do I think I'm more like cutting and blood, or am I more procedural, non-cutting and blood, which would then be like GI and interventional radiology? So there's so many ways to kind of think about the different specialties in medicine, and diving into it sooner rather than later is highly advisable.
Thank you.
Yeah,
All right. Does anyone have any other questions? Okay. Is it okay if we share your email in our Slack, Doctor, if that's okay with you?
of course, of course. Yeah, you got my email, and then my Instagram handle is Dr. Nakra, which is pretty easy. So you guys can reach me on social media as well. But
Great.
anyway, very nice speaking to you all. I wish you good luck in your path. Get the best grades you can. That's I'm on the residency selection committee for Del Med for ophthalmology. I can tell you the GPA really matters, not just for medical school, but we still look at GPAs for residents, undergrad GPAs when people are applying for residency programs. We look at we also choose fellows in my practice as well for oculoplastics because we have a certified fellowship, and we go all the way back to the undergrad GPA also. So, get the best grades you can. And then the MCAT score matters. So do whatever you can to get the best score you can. Those are the two things that are going to really open doors for you. And then, yes, of course, all of the things that make you well-rounded, exposure, definitely, research and trying to get some publications at this stage. Those are all important as well. And so keep it up. It's worth it. You guys can do it.
Could I ask a quick question real quick?
Sure.
This is kind of off topic, but what's the lowest GPA you guys would accept? This is kind of random. I just was curious.
Yeah,
Have you ever came across a resume and you were like, interesting, but you still accepted?
So I would say across the board, medical school acceptances, residency acceptances, fellowship acceptances, anything below a 3.6 is usually kind of not going to work. And so that's something just to kind of keep in mind. 3.5, 3.6 is sort of like the bottom edge. Anything below that is going to be difficult, very difficult to kind of access a career in medicine. The higher you get, the higher it is, the better. But that's sort of the bottom edge.
I kind of have a friend right now. She wants to do a post grad, get her master's in medicine, in sciences, to help with her GPA.
Yep.
Because right now she has basically maybe a 3.1. And I told her, I was like, I don't know what to tell her, advice wise. So I was wondering if you had any advice on that.
Yeah, a couple things she could do. Well, I mean, what year is she?
She's a fourth year. So she's we have the same major. She's a human biologist major as well. So she's graduating this year.
So with a 3.1 GPA, medical school is going to be out of reach. So there's several things she should be considering. One is, unfortunately, she should be considering careers that don't result in an MD, just because she has to maybe find some practical choices. So there are other very nice careers that are in the medical world. Optometry, dentistry are options that interface with human health and have rewarding careers. There are also options for going into integrated programs where you do an accelerated master's, and depending on your grade level, you can get a conditional acceptance to medical school. There's several programs like that around the country, and if she aces all her classes, she might be able to have an option for medical school from there. And then there's also DO programs and MD programs outside the United States. And I know those are all tough considerations for someone who really has their heart set on a US medical school, traditional medical school. But the reality is that, even an international MD program or a DO program produces physicians that can practice in the United States. And, coming from a DO program or a non-mainland US MD program, like in the Caribbean, for example, those medical school graduates are not going to be competitive for competitive residencies, but they could easily go into internal medicine or general surgery and kind of branch out from there and find a career that could be quite rewarding. So those are all options for people who don't have great chances of getting into the traditional path of an MD program after undergrad.
Okay, thank you. Yeah, because she wants to be a pediatrician. That's like her lifelong goal. And I was like,
So pediatrics is not a competitive residency program.
okay.
So it is very feasible for her to be considering a DO program or an MD program that's in the Caribbean or outside the United States, because she would probably be able to get into that kind of specialty, with an alternate path.
All right, thank you. Appreciate that.
Mhm.
All right. Thank you so much, Doctor. Thank you for joining us today despite your busy schedule.
Of course, of course. You guys have a great evening, and good luck, and stay in touch if you guys need anything.
Thank you.
Wow.
Thank you.
Bye-bye.